Okay, Sheren, we're live. I'm just going to give people a couple of minutes to start to come into the webinar. Give them a little bit of time. And already, this is great. So hi, Andrew, hi, Tina, Barbara, Helen, lovely to see you. Lucy, Maria, Sarah, Sheila, how lovely to see you all. Thank you so much for joining us today. I'm really looking forward to this one.
I'm really excited.
So because we've got so many people here already, I'm just going to say hi and welcome to Coffee with Cathy. I am really pleased today to be talking with cognitive hypnotherapist and chronic pain specialist, Sheren Gaulbert. And when I first saw Sheren speak, which I think was last year, it really opened my eyes. I thought I knew something about it, but it really opened my eyes to understanding more about pain itself. So welcome, Sheren. Thank you so much for spending some time with us today. Really,
my pleasure.
Great. Before we kick off, I want to tell you a little bit about the technology we're using. We're using a system called Zoom. And if you have questions, there is a chat box. If you're on a desktop or a laptop, the chat box you can see at the bottom. So if you have anything you want to say, pop into that chat box and type in any questions. We are aiming to go for about an hour, but you know how it is sometimes with these subjects, we have so many questions, we might go on a little bit longer. So if you need to hop off at the end of the hour, don't worry, we completely understand. And if anyone wants to continue for a few more moments, then we can carry on with questions. That's okay. So brilliant. I was going to do a real introduction to Sheren, but then I thought, you know what? I'd rather ask her herself about what she does, because I'm not going to do it justice. So Sheren, could we kick off by asking you a little bit about how it is that you help people right now?
I primarily work with chronic pain clients, people who've been in pain. By the time people get to me, it's usually been quite a while. They've tried a lot of things by the time they get to me. So I use a blend of cognitive hypnotherapy, pain education, the biology of what's happening inside someone's body, because that is really powerful stuff. When you understand how pain works and what's going on internally, it gives you back some of that. It gets you back in charge of your life almost, because you know why it's happening, and that's really powerful stuff. So pain education, cognitive hypnotherapy, and lots of other things that we fit around the individual in front of us, because that's what it's all about. There's no one size fits all. Yeah. It's just not that easy. We are complex beings. Yeah, so that's what I do. Yeah.
Brilliant. And do you mind if I ask you, I know you've got a little bit of a story yourself, do you mind if I ask you how you first got into working in this field? It's a very specialist field.
Yes, I do have a story. I suffered with chronic pain for almost a decade. The first year was particularly tough because no one seemed to believe me. Well, the doctors didn't anyway. And that story is repeated over and over again. It's such a common experience. So for the first year, you know, the GP looked at me sideways, pretty much implied it was all in my head. I wasn't imagining it, it was real. Yeah. And we'll probably talk about that later. But then did get diagnosed, but actually I had symptoms much earlier on than that. So I was aged about 21 when it got to a head, and I had pelvic pain. But actually my symptoms started when I was 4, and I had the symptoms of IBS, and they carried on, but no one really picked it up. So it kind of got to a head at age 21. And at age 22, I was put on medication and started increasing the medication. But everything just got worse. Nothing was working. And I had conflicting advice from different specialists, which again is quite a common experience for people. And, you know, things like, oh, just go and get married and have kids and you'll be fine.
No.
Am I really hearing this? This is a GP. And you'll probably have to either work part-time, look for other work, or have to stop working completely. You'll have to take a lot of bed rest. Now, I'm one of these really stubborn people, so I just thought, I'm just going to be really stoic and carry on, which I did for a while. But unfortunately, the pain got so bad I was passing out from it quite regularly, so I had to stop working altogether.
Wow.
And then I kind of slipped into a bit of a low. And then, I don't know what happened, but I just suddenly woke up one day and just thought, you know what? I'm too young for this. There's got to be another way. And I just started immersing myself in different therapies. And I'm kind of quite scientifically minded, so 4 to 6 months on each different therapy.
Wow.
And it took me a long time to find the thing that helped. And the thing that set me on the right track was self-hypnosis, which I didn't know there was any evidence behind at that stage. I just got to a point where I seemed to have tried everything. And I thought, right, let's give this a go for 6 months. But actually it took 7 days. And I'm not saying I went from, you know, the state of pain I was in and passing out to completely fine in 7 days. But it did mean after 7 days that I was able to leave the house on my own.
Gosh.
For the first time in so many years. So it was a big change in a very short space of time. And then I went on to study to find out why it was working. So it's kind of led me to this path.
Yeah, that's absolutely amazing. And that's from scratch as well. It's incredible.
Yeah.
Can you sort something out for me? This is a question I know lots of people have, and it was something I was a bit confused about. We talk about you being a chronic pain. I can't say it. Chronic pain specialist. So what exactly is the difference between chronic pain and acute pain?
Okay. Yeah, that's a good question. The simple answer is acute pain is short-term pain. It's the kind of thing you have after an injury. So there's a healing time involved in that. That's acute pain. Or if you have the flu, for example, and you get those kind of aches and pains all over, that's your immune system releasing these lovely things called pro-inflammatory cytokines. All they're doing is they're giving you a bit of pain to let you know you need to rest right now.
Yeah.
So that's acute pain. It comes and goes, and it serves a really good purpose. Chronic pain is something that's overstayed its welcome. It no longer serves a particular purpose. So that's a short answer. Looking at just the definition of pain in and of itself, without the chronic and the acute, pain is a sensory and emotional experience all of the time. Whatever type of pain you have, it's always sensory, i.e. physical, and it's always emotional. And that is the definition of pain. So the International Association for the Study of Pain defines it as an unpleasant sensory and emotional experience associated with tissue damage or potential tissue damage. So there doesn't have to be any damage there for you to experience pain. We'll probably go into that a bit later. So that's pain. So there's no kind of, it's all in your head or just in your body.
That's really interesting. So there's always an emotional component to it?
Always. Wow. It depends what you mean by emotion as well. So when we think of emotion, we think, anger, fear, guilt. Yes, absolutely. But think of them as they're physical, biological messages inside you. So if you think about emotions or thoughts or the things you think of as physical, all of them are physical. You know, when you're having an emotion or you're feeling something, there are physical chemicals running through you. So you can't untie one from the other. they are absolutely bound. We are complex beings. Everything is interconnected. We've got all these interconnected systems that interact and talk to each other all of the time. So always both. And, you know, we got into this thing with the 17th century philosopher Descartes, who was the one who came up with this. He was probably the first person who came up with the theory of pain. And he split body from mind.
Yeah.
He thought if you hit your thumb with a hammer, then there must be pain receptors sending messages down pain nerves up to the brain saying, my thumb hurts. Now, we now know that's a nonsense. But hey, that guy was only doing the best he could with the information he had, right?
Yeah, and it makes a lot of sense, doesn't it? It feels right, yeah.
It seems right, doesn't it? But he was kind of observing. We were observing people from the outside. We couldn't look inside to see what was going on back then. Whereas now we have the beauty of MRI scanning and technology now. So we know that's not how pain works. But, you know, and that's 400 years old, that stuff. And there are people that still hold on to that. And, you know, we're moving away from that because now we've got the evidence that that's just not how pain works.
Right.
Just because there's something going on with your thumb, or just, you know, because there seems to be some sort of damage, doesn't necessarily mean you experience pain. It's a little bit more complicated than that.
Well, that brings me on to another question, actually. You know, we're talking about chronic pain that's outstayed its welcome, and how you can actually help with that. And I know you can, phenomenal. But then, and we're talking about emotional pain. But what about a situation where someone's been in for an MRI scan, for example, and they've been told, right, look at this, you've got this slip disc. You know, is there anything you can do to help, or do you have to live with that because it's a physical reality, if that makes sense?
Yeah, I love that question, and that is such a common question. You know, people often go, well, yeah, but I've got something physically wrong with me.
Yeah.
Now, this is, again, where our understanding of pain has moved forward so much in the last couple of decades, in the last 20 years. Just because there is evidence of something that looks physical, like a slip disc. By the way, discs can't actually slip, but we won't go into that because that's a whole nother conversation. Or something's bulging, or something's compressed. Sounds painful already, right? These words.
Trapped nerve. That sounds
nerve.
painful.
Oh wow! All of it sounds really painful, and then you get the evidence. Look at this, and actually, you know, we got carried away years ago when doctors started using MRI scanning technology. They thought, yeah, let's show our patient the evidence. This is what's going on. This is the thing that's causing your pain. But actually what we found is that makes people's pain worse, because they then think, oh, well, that's the thing causing the pain, except it isn't. Just because there's something, a mechanical thing going on, doesn't mean you have to experience pain. The injury or the disease or whatever's going on mechanically doesn't correspond to the severity of pain.
Okay, I'd love to understand a little bit more about that, because again, my head's going, no, surely that's there and it's physical, it's real, and you can see it. So,
okay. Another way to look at it is, if you think of, we're sensory beings. So before I go into pain, let's think about another one of the senses, which is sight. So when you see an optical illusion, and we've all seen optical illusions where we see one thing and there's something else going on, or we're kind of a little bit fooled by what we're seeing in front of us. And they work because it's the brain that does the processing. What goes in through our eyes, it's not the eyes that give you the final result, it's the brain. So the eyes take, the nerves from the eyes take the information through to the brain, and the brain goes, what do we know from our past about this? What's this like? And then it presents you with what it thinks you're seeing. And we know that's not actually what you're seeing, it's an optical illusion. Pain sort of works in the same way. So let's take the hammer and thumb incident, for instance. So we've got it hitting your thumb. There are no pain sensors, but there is a neuron with lots of different sensors on the end of it. There's lots of neurons with lots of different sensors, but let's just take one of those neurons. And all the sensors have different duties. Some of them deal with temperature, some of them deal with pressure, some of them deal with chemical stimulus. And if you've hit your thumb with a hammer, it would be the mechanical receptors, the mechanoreceptors, that send a signal after a certain level of excitability in the thumb. And if you've hit your hammer with a thumb, it's going to happen.
Yep.
Sends a message up a nerve, not a pain nerve, just a nerve, up to the spinal cord. And at the spinal cord, it meets another neuron, and it passes the message on. Now, that message at the spinal cord is one that goes up to the brain, and it won't necessarily take a message up to the brain. If the brain has already decided everything's okay, the brain is already sending lots of messages down going, everything's fine here. But let's say that message goes up to the brain, then the brain decides based upon past experience, beliefs, things it's observed in others, things it's learnt, all of that stuff. To dive into, say, all the folders of the brain, checking through the archives, what's this like? And then it matches up what it thinks is happening here and decides what to do. So it does an evaluation. And based upon that evaluation, it acts.
Yeah.
So pain, remember, is a protector. It serves a really, really good purpose. So if it's acute, fabulous. If you have hit your thumb with a hammer, then we want there to be inflammation. It means fabulous stuff is happening. The healing is beginning. But if you haven't hit your thumb with a hammer and your brain is concluding, oh, that little pinprick is something more than it was based upon past evidence, that's where we get into trouble. And the key thing, just as an idea of how powerful the brain is, for every one message that goes up from that thumb, 200 come down from the brain.
Wow.
Every one up, 200 down from the brain. And those 200 can calm everything down or amplify everything. That original signal is like an alarm that goes up. It's sounding an alarm. It's a bell that's ringing. And then the brain can just amplify it or mute it or calm things down for you.
Right. That's amazing, because I'm really beginning to see how it isn't just a fait accompli that you hit your thumb with a hammer and it's therefore pain. It's much, and therefore presumably with some of the stuff that you work with and means that you can influence that balance between the amplifiers and the dampeners. It's probably completely the wrong word, but so how interesting.
Yeah.
But the other thing is, you know, I've met, very similar to your story, but I've also met people who said, look, I've tried this, I've tried that, I've tried all these different things. Yeah. And you yourself went through that. So why is this approach any different?
Well, it's a modern approach, and it's steeped in what we know about pain right now. And the modern approach treats you as a whole person. So there's never going to be, if it's chronic pain, there's not going to be one cause for that.
Right.
There's going to be a number of things that are making your brain conclude that your body's in danger. And it is all about danger. Your brain is doing a threat assessment or a danger assessment in the moment. But if you've just, you know, pricked your finger with something and your brain is sending a huge amplification signal, then we know that something's not quite right there. So we get to the bottom of what is it that your brain is concluding is dangerous? And that may take a few layers of things. And when your brain concludes it, it takes information from all the senses. So it might be things that you're hearing and seeing outside of you that are also contributing to the amplification. You know, things like a good friend kind of going, oh, are you all right?
Yeah.
Are you okay? Can I help you with that? Unfortunately, that's lovely of them, but that can amplify symptoms because you're getting attention for the pain that you're in. And so your brain kind of goes, oh, I'm getting a bit of attention here. Might just amplify that a little bit, see if we can get a bit more. Now, that's not true of everyone, but it's how things can get confused and muddled in the brain. So it's a modern approach. It blends pain biology education, but in a really simple way so that you can understand what's happening inside your body. And as I say, that's a really powerful thing. Blending that with what are the specific things that are amplifying your symptoms and working on those individual things. So is it the messages you've been getting from doctors? Are the friends around you treating you differently? Is it that you're protecting the air, overprotecting the area? Is it that you're no longer going out and mixing with the community or enjoying some of the things they used to enjoy? There's so many things that can be amplifiers. So working with a specialist means you can dig down into all the things that could be amplifying those symptoms. So not one cause, but many causes that sustain that experience. And as I say, it is a complex integrated system. You know, we're talking about the sympathetic branch of the nervous system. That's a fight or flight response that kicks into action when the brain thinks you're in danger. The endocrine system, you know, cortisol you hear about, which is the stress hormone, which kind of dampens down any reproductive activity. You don't want to be having sex or digesting food when you are in danger, or the brain perceives there's a danger there.
Makes sense.
Not useful things. So it's getting you ready for fight or flight. And the immune system response can sustain that inflammation, which means it kind of worsens things. So it's working on all of those systems.
That makes a lot of sense. I can also see how probably just having more of an understanding of that in itself can make a difference.
Absolutely.
Say you are in that situation. I've just hit my thumb with a hammer. And my good friend is coming on, so there, never mind. Just by understanding could presumably make a difference.
Yeah. And acute pain is different because if you you've hit your thumb with a hammer, you probably do want to protect it. You know, that's fine. You know, pain is serving a really good purpose there. It's saying you're in danger, protect the area, let it heal. Really useful. But when it's chronic and it's gone on for, and chronic is anything that's gone on for over or the usual tissue healing time, tissue, muscles, tendons, ligaments, and that can be 3 to 6 months. Anything over that is classified as persistent.
Right.
In general. So when it reaches persistent pain, then that's no longer serving a purpose to protect the area.
Yeah, that makes a lot of sense.
Because that's not the thing that's causing your brain to think it's dangerous. There's something else going on there. There are other things that are amplifying that signal.
Yeah. You've just reminded me actually of something I read that you wrote, and I wanted to tell people about that. You've got it's a series of emails, isn't it?
Oh yeah.
Let's see if I can get that. I'm going to put the link into the message box if I can find it. And what Sheren's got, bear with me, is something that explains a lot about how this works, which I found absolutely fascinating. I think, there we go. That's gone out now. So if you go onto that, you can get a copy of that, I believe, from Sheren. I really would recommend it because it explains it so beautifully.
It explains the biology in a really kind of manageable way. So it's a series of 10 emails. So you get a really short email each day introducing a little concept. And it's lovely because you're you go to sleep at night, your brain processes that, and then you have another email in the morning, and it kind of just gives it to you in bite-sized chunks. 7 Keys to Reducing Your Pain Now is a free email series. Yeah.
So if you go into your chat box, I think you should be able to see the link. I've typed it in anyway, so let me know if you haven't got it, because I can always send it out. But, you know, talking again about the chronic and acute side of things, there are people who have been suffering for years and years, you know, 20, 30 years or more. And with some people, it just gets worse too, or it spreads from one part to another, or it seems to.
Yeah.
Now, you know, hearing that you're amplifying and dampening it yourself, I can imagine that won't necessarily be taken that well, to think, well, actually, look, I have suffered for so long, I've been having this for so long. Is it still possible to help someone who's been suffering for that sort of length of time? Or is it so ingrained that there's nothing that can be done?
Okay, yes. Yeah, great question. We often think that if something's been going on for a really long period of time, then that must be so. It's kind of in concrete. That's just not how we work as human beings. We're not robots. You know, we are constantly changing beings. So people have probably heard of the concept of neuroplasticity, how the brain is constantly changing. So as you're listening to me now, and people on the call, your brain is changing right now as you're listening. It's making changes, it's learning stuff, and later on it will store things away. Those are longer term changes. Those changes happen very, very quickly. So that's neuroplasticity. When things get worse in the body, or they spread to other parts of the body, so for example, let's say the pain in your thumb hasn't gone away after 6 months. And then sometime later, you start getting a pain in your head. You think these two just aren't related. How do these two link up? But actually in the brain, in the somatosensory cortex, we've got a little representation of the different parts of our body. And our body isn't represented in our brain exactly as we see it in person. The parts are all in slightly different places, and the bit for the thumb is next to the bit for the forehead.
Okay, yeah.
So with the concept of neuroplasticity, knowing that the brain changes, if something has been persistent for a while in the thumb, the thing that changes is the thing in the brain. So the changes are happening in the brain. Remember, the brain is the one that sends those messengers down to dampen down or amplify things. And if something's been firing for quite a while in the thumb area in the brain starts thinking, well, that's quite important, and it might start spreading out to take over more parts of the brain, adjacent areas. And an adjacent area would be the forehead in the brain.
Because it thinks it's kind of important, as it were. It's just like...
Yeah, it's thinking, oh, that thing that's happening in the thumb, that's really important. We better keep on amplifying that. And it just takes up more space in the brain. And so it might overlap over to the forehead. Now, again, that's not going to be true of everyone. It will overlap, and everyone's brain is slightly different. So the areas affected will be different. But yeah, the pain can spread for that reason. So that's the changes in the brain. But there are other changes. There are changes in the body as well. So we call this bioplasticity. So it's the biological changes in the brain. So putting it really simply, if there's something happening in your thumb that's been happening for quite a while, do you remember we talked about the end of the nerve, the neuron at the end with the different sensors? And these sensors have these little gates on them that open and shut like this. And ordinarily they keep shut for quite a while, and then they let in these kind of positively charged particles into that neuron. And it's going to take quite a lot of particles getting into that neuron for that neuron to then send a message up to the spinal cord and up to the brain in the first place. So it needs to be a certain level of excitability, they call it. The problem with chronic, when something becomes chronic, is those gates that usually stay closed for quite a while can stay open for a really long period of time.
Okay.
And they let in more and more particles. So that it takes less and less things to happen for the pain experience to emerge. Does that make sense?
It does. That makes a lot more sense. Yeah.
And then there's changes once that fires up at the spinal cord where it meets the other little messenger going up to the brain. There are changes there too. And we might not have time to go into that today, but if we do, I'll come back to it. But there are all sorts of changes. So changes in the brain and changes in the body. The happy news is these sensors that might stay open for quite a while, whatever those sensors are, only have a lifespan of a few days.
Now that is good news, because I was beginning to think, actually, this isn't so good, is it?
So, you know, this is why we're constantly evolving, changing beings, depending on what we're picking up, what we're learning, you know, whether we're in therapy, whether it's a physiotherapist or a cognitive hypnotherapist or another type of therapist, the body and the brain are constantly learning, and it's learning to change. Mm-hmm. So if that sensor and those sensors only have a lifespan of a few days, that kind of identifies why I was able to get out the door in 7 days. I didn't know that back then.
Yeah. Wow.
But
yeah,
it kind of gives you more hope when you know that that's how quickly changes can happen.
That's exactly the word that was coming to mind. I'm thinking, wow, this gives absolutely everybody hope, doesn't it?
Yeah.
It's just amazing.
Yeah, it is.
So one of the other things that does come up is that, and I think we've spoken about this before as well, how some people go to their doctors and their doctors give them antidepressants and say, well, you must be depressed. And, you know, there are people that say, well, I don't think I'm depressed. That's something you've come across, isn't it? Because we've spoken about it before.
Yeah.
Well, what would you say to someone that's been told that?
Yeah. Now, it depends why the doctor has prescribed the antidepressants. With pain that has been sustained over a long period of time, we're talking about a pain that is associated with the nerves and not with the tissues. When it's persistent, it's something that's usually to do with nerves misfiring or those plastic changes. If a doctor has prescribed you something like amitriptyline or nortriptyline, known as tricyclic antidepressants, those medications are no longer used for depression. They are used for pain. They're used for pain.
Okay.
They used to be. Back in the day, they used to be used for antidepressants, but what they found was a side effect that numbs the pain experience. So it's now used for pain. So if people have been prescribed that, that'll be the reason. It's not for depression. It's to numb it. Doesn't work for everyone, but I think the numbers to treat are, I think, 3 or 4 people before it's efficient. It does its job. So every 4th person, I think, it works for.
Right.
So that's why someone will be prescribed that. If the doctor is prescribing another type of antidepressant, then perhaps you might have that conversation with your GP as to whether he thinks you are depressed. Actually, all of this is really good. You know, just communicating with your GP, jot down those questions, go in. They have 10 minutes, you know, to do, usually an incredible job.
Yeah,
but the thing to bear in mind is that, you know, GPs and doctors, they do 7 years at medical school. That's a hell of a long time. But the amount of time devoted to pain is about 7 days in that period of time. And most of that is to do with the mechanics of how pain works rather than the biology of how pain works. And it's to do with what medications to use. So forgive GPs if that's the first thing they offer you. But tricyclics would be the first thing you would probably be put on anyway.
Right.
But it's not necessarily a long-term solution. Have a look for a multimodal approach is what works best. So for some people that means some medication, but certainly something physical, whether that's a physiotherapist or doing yoga, together with someone working on what's going on up here, is the best approach.
Right, that makes a lot of sense,
Yeah.
So typically with your clients, you might be seeing them in conjunction with them seeing other professionals.
Yes. And certainly with a manual therapist. Not in all cases, but in many cases, that's you're treating the whole person.
Yeah.
The model that's used is the biopsychosocial model. So all that means is the biology, what's going on internally, the psychology of what's going on in your head, the social, what is your social dynamic like, who are you hanging around, what's happening in the environment around you, are you connected to other people? It's a complex thing that we're working on. So that doesn't mean having lots of different psychological therapists.
Yeah.
It's finding the specialist that works for you, whether that's a cognitive hypnotherapist or a different type of hypnotherapist, and a physiotherapist, or a different combination. So it's finding that combination that works for you.
Yeah, good stuff. You've just brought up something that's reminded me of with my work with addiction. You know, you're not just necessarily, so I'm going off track a little bit, I hope you don't mind, Sheren. You're not just necessarily treating the person in front of you, because you talk about the social side of it. You know, for someone that's had an addiction for a long, long time, for example, their family are involved, their work may be involved, and new roles come up of carer and new habits and ways of being come up. So it's certainly in that field. I should imagine it's the same in your field as well. For those of you who are on this, who are therapists, you know, you guys know all this already, but you know, it is a complex dynamic, not only within that particular body, but also with all the interactions of people around them and how that might impact them. You know, a family member being really, really caring and wanting to help may have been given a role which gives them a form of status. Of course, they're not necessarily aware of this, which gives them a reason, you know, a raison d'etre, as it were. So all of these things, I think, have to be handled.
Absolutely.
Yeah, with sensitivity, but understanding. So I guess education.
Yes,
really
and
important.
You could imagine that if you're in pain and you've been educated and you now kind of understand how pain works, then you can talk to the people around you as well on that level and let them know as well. So, you know, there's no blame here because they didn't know. And, you know, this is all about getting to know your body better, understanding what's going on and communicating that to other people around you with love, with compassion. You know, we didn't know better, so, you know, or they didn't know better. So, you know, having that conversation. I had this lovely friend who used to phone me up when I was in pain. She'd phone me up. She'd go, "Oh, Sheren, you're so brave." And she was lovely. I loved her to pieces, but I couldn't work out back then why. Sometime after a call, I would always seem to have a flare-up. I'd always get worse. And it was the attention I was getting, the focus of attention was on the pain. You know, my brain was kind of, what am I being brave for? Oh yeah, being brave for that thing. And I was getting attention for it. So the thing to do is kind of talk to that person and go, actually, this is how pain works. And carving out a new role if necessary. So rather than attention for the pain you're in, attention for something else that you've achieved. And, you know, if it's a small action that you've done, something you've done differently, a little step forward, attention for that kind of stuff. Encourage people to give you attention for that kind of stuff instead. So you're removing the old attention that used to amplify symptoms for new attention that kind of calms things down and makes you feel better.
Just made me realise how important this stuff is to understand. Because for those of us who aren't experiencing that, we know people who are, and we may inadvertently be making things worse without knowing. Because it's difficult to know sometimes if you don't understand that yourself and been in that situation, what it is to say and how to try and make it better. So it's a really, really good point. I think, you know, I might have another look over your documents to remind myself, because, you know, we behave differently as a result of understanding this.
And it's not the easiest thing to do, is it? Because, first of all, it starts with, if you're in pain yourself, kind of looking at the language you use yourself. I'm always going to be in pain. This is hopeless. I'll never get better. So starting to look at the language you're using that might be amplifying things. Remember, if you're thinking something or you have a belief, that's a chemical too. That puts you into fight or flight too. Those are those 200 messages coming down from the brain going, this is really dangerous. So working on yourself first and then communicating out to other people, actually, I'm having to make some of these changes. Are you with me? Could you kind of do that too? And expect to get it wrong at first.
Yeah.
It's not going to be easy. We live in a society where, just look at the news. It's not really the news, is it? It's pretty much bad news that's presented to us, 24/7.
Absolutely.
It's not really news. So we live in a society where we kind of are surrounded by bad news, a negative slant on something. When I ask people, how would you like to be, when you're better, what would you like to be doing? How would your life be? And they'd go, I'll be pain-free or won't have pain. And remember, both of those phrases include the word pain. Yeah. So the focus of you might see a blue elephant here. Can you see a little blue elephant in the background?
Oh, yes.
If I asked you not to think of a blue elephant, what happens? Yeah.
You can't help it.
You can't help it. You've seen him there, even if you close your eyes, and I don't think of any type of blue elephant. Your brain has to do it in order to know how not to do it. So if you say you don't want to have pain, or you want to be pain-free, what you're signaling to your brain is the word pain. Mm-hmm. That's the thing that's highlighted. So we're kind of changing the focus from that, the pain, to something else. What is it you want instead? If you don't have the pain, then what does that mean for you in your life? Mm. What can you do instead? So and then working out, how your life would be different and the specifics of what you'd be doing. Would you be, I'll, see a friend more often, or I'll go swimming once a week, or it might just be, I'll go for a walk for 2 minutes and back again. It might be tiny, tiny steps, but identifying that focus of attention and letting other people know, look, this is what I'm going to do. I'm going to walk for 2 minutes today outside the house and come back. And getting your friends on board, your loved ones on board, is a great thing, because then they can kind of go, did you do it? And if you've done it, it's like, yay, a little celebration.
That's brilliant. Yeah, I love that. It's just looking at it from a different angle, isn't it? It's just taking that focus to something far more positive.
Yes, absolutely. Yeah.
So you alluded to this actually. It kind of moves on to something you mentioned right at the beginning, which is, if something has been going on for so long, then it must all be in your head. Pull yourself together. Or you must be imagining it, because there's no physical cause. I mean, do you get that a lot?
Yeah, absolutely.
And if someone's experiencing that, how would they respond?
Again, this is where finding out how pain works comes in handy. So if you know that, pain is always a sensory and emotional experience, your brain decides whether you're going to experience it or not, because it's doing a little threat evaluation. Is there danger? Can I perceive any danger?
Yeah.
And what it's doing is looking into your past experiences, the things you've learned, the things you're hearing from the environment around you, the beliefs that you have, the thought patterns. It's a complex thing. You're not imagining it. Pain is real. It's real. If you're feeling it, then it's a real thing. It means that chemicals are flowing. There are messengers flowing between brain and body that mean that you're experiencing this.
Yeah.
So absolutely, you're not imagining it. If someone says it's all in your head, and they're implying that you're imagining it, you might kindly educate them a little bit. The 7 Keys to Reducing Your Pain Now series talks through some of those points, and you might like to introduce some of the people who might be implying that you're imagining it to it, or talk to them about it, talk to them about the things you're learning.
Yeah.
However, it sort of is in your head in the sense that your brain is in here and it's the one that's sending, you know, amplifying the original alarm or calming things down.
That's
So
a good thing, isn't it? Because that's the thing that's giving us hope. If it was as simple as you've got something wrong here, then we may as well give up now. So I love that. It's just giving us real hope. So and also I think of the example of phantom limb pain. I should imagine people about that all the time. That presumably works on the same the same principle. It is as just as real.
Absolutely.
Something else.
Absolutely. And a huge percentage of amputees do experience phantom limb pain. It's absolutely real to them. The reason for that is, you remember the somatosensory cortex with a little representation of us inside our brain. If someone's arm has been amputated, what tends to happen is that area of the brain is no longer being used anymore, because there isn't a feedback, because it's a feedback loop that happens. There's a lovely little messenger system between brain and body happening continuously. But if the arm is amputated, there's no longer that loop. Those nerve endings are no longer there. However, the bit in the brain is still there. And what tends to happen is, as it's not getting feedback from what used to be there, an adjoining area will grow into the area that used to belong to the amputated arm. And so, depending on what that adjoining area is, let's just imagine it's the cheek, for example, is the adjoining area in the brain. It can be that a little bit, someone touches you on the cheek, or a gust of wind goes by, and those receptors are sending messages to the brain, but they're now in the position where that arm used to be. There's a confusion there, and that amputee may feel it in their phantom limb.
Gosh, that makes so much sense.
Yeah,
so much to learn.
Oh, there's so much.
Given that there is so much hope, I've got to ask you this: if there is someone either listening or who knows someone that's been experiencing this, what is it they can do to get free of pain? Sorry, I used pain-free. To get free of pain as quickly as they can. What is the next step?
That's going to be different for each person. Getting rid of the pain isn't necessarily the first step. As much as we want it to be, I want to be pain-free immediately. Because let's think back. If the brain is concluding that there's something dangerous, it's perceiving a threat, it's sending you into fight or flight, it's sending them down these 200 chemicals that are amplifying that original danger signal, that danger message, that alarm, then what happens if we take a painkiller or we use a pain reduction technique straight away? Well, the brain still is going to conclude there's danger. We're masking over a symptom, but the brain still believes there's danger. At some point, that medication or that technique may stop working, because the brain is going, you're not listening to me. I'm telling you there's danger. You're artificially dampening down the messengers that I'm sending. I'm going to amplify this even more. And it breaks through whatever it is that you're using, whether that's medication or a technique, a pain reduction technique. So the first thing to do is always to look at what's amplifying that signal. What is the brain concluding as being a threat or dangerous? So that's always going to be the first thing. Having said that, there is, for people with experiencing chronic or persistent pain, there's a high level of sensitization. They might be a bit jumpy, the nerves are firing a lot more than they need to. There's a lot of communication going on. One of the first things to do is probably to just start relaxing the nervous system. The nervous system is the messenger pathways, if you like, between the brain and the body. So the first thing probably to do is just to start calming things down a little bit. So something like using something that relaxes you would be a good way to start.
Right.
And then to look at what is the brain concluding is dangerous. And you might need the help of a therapist to dig deeper and find out what those things are for you. Because believe me, we're usually not consciously aware of what those things are. As much as we can probably identify a few things, there are going to be other things there, things that we just didn't expect.
Yeah.
Could be kicking off a reaction right now, but things way back in our past, something that we learned about how to behave when someone's hit your thumb with a hammer or you've fallen over. But it could be something really innocuous. And again, something like cognitive hypnotherapy or hypnotherapy can sometimes get to the root of what's really going on there, because these are automatic signals that are happening.
Yeah.
You know, we're not aware. They're like that. They happen faster than that. You know, and the brain is control. You know, it's an unconscious response. We're not aware. We can come along after the fact and kind of justify, right, this is probably what's going on. Yeah, it probably isn't. It might be one of the layers, but it probably isn't one of the main things. So certainly a therapist to dig a bit deeper with you. As I say, a multidisciplinary approach usually works best. So if you've got someone working with what's going on here, the thoughts, beliefs, and the unconscious patterns, the things that are kicking off that danger response, then, you know, sometimes physiotherapy or doing something else can help too. For people at home now, if they wanted to do something, you know, I mentioned the 200 messengers coming down from the brain that amplify things.
Yeah.
Remember, the brain can also conclude everything's fine here and send 200 messengers down that calm things down. And those lovely, lovely messengers are really, really powerful. And we group them together. So the things like endorphins, dopamine, oxytocin, serotonin. And together, these lovely, fluffily named happy hormones are 60 times more powerful than morphine.
Wow. That's amazing. Sorry, I mean, I know I've heard this before. I don't think it quite sunk in the first time. 60 times. 60 times more powerful than morphine. And morphine is the thing that we use to knock people out when they're having an operation. You know, now I'm not saying let's release all of those happy hormones at once, because you don't want 60 times more powerful than morphine all of the time. You're not going to be particularly useful in the world. But you have access to these lovely hormones that are so much more powerful. You know, these are the most powerful pain-killing substances, and they're produced by our lovely brain. You know, they're triggered by the messenger system between brain and body. That's quite incredible. Knowing how to release those. Do we have time for me to just tap into one of those, maybe? Let's do that, because we haven't quite done the hour. We've been really good, actually. We haven't. While I try and work out, I've got 2 people have put their hand up, and I'm desperately trying to work out how I can find out about that. So apologies for that. So yeah, I would love to hear that. It'd be really helpful. Okay. So I think the easiest one endorphins is a good one. Endorphins are released, probably as most people know, when you exercise. And getting moving is really important if you're in persistent pain. The old advice used to be rest. That's not the advice anymore, because if you rest and have bed rest, like I was advised
when I was in pain, it only serves to amplify things. The brain thinks there's more to protect, and it keeps on protecting by amplifying things for you. So getting moving is important. That doesn't, a little stretch, not going from not doing very much to doing a full workout in the gym. No one's saying that. So this is why it's important to work with a professional that might kind of identify what's the right small little stretch for you. But the other lovely, easy way of releasing endorphins is laughter.
Brilliant.
So, that's the thing I would say to anyone at home, and get into the habit of having a real belly laugh. Whatever it is that gives you that belly laugh. It might be watching, a funny YouTube video, a cat video, whatever it is that, makes you have that belly laugh. But it's that anticipation of having the belly laugh too. That moment where you can feel you're about to laugh. That releases endorphins too.
Wow.
So it's a really powerful substance. So I know we've got other, we've got oxytocin, serotonin, dopamine, but I would say endorphins probably the easiest one to apply straight away.
It sounds great. That really sounds good. And great fun too, obviously.
Yeah.
Brilliant. Now, I've got two hands up. I've got Heather and Tracy have put their hands up, and I just wondered if they had, I apologise for not seeing it earlier. I was so engrossed in what was being said. But if you have any questions, then can you pop them in the chat box, just so that I can see if there's anything outstanding that we need to talk about, or I need to ask Sheren while she's here on the hook, as it were. Okay, I've got hands up rather than chat. If you could possibly type something in the chat box to us or to everyone, that would be really helpful. Okay, great. So Moira is saying, I'm really enjoying this, thank you. I'm interested in Sheren's background in terms of training. Moira, is that in terms of you being a therapist? And just in case there's anybody else who's interested in that. Again, this wasn't what this webinar was for, but if you're interested in that, I believe Sheren does do training for therapists.
I do, yeah.
What I'll do is at the end of this, I'll pop up your homepage, if that's okay.
Yeah, sure.
You can find out how to contact you. I was going to ask you that anyway.
Yes. Yeah, that'll be the easiest way, yeah. Okay, I do offer pain therapist mentoring, one-to-one. My background is my personal experience, obviously. I trained in cognitive hypnotherapy, human givens, the neurobiology of pain with the Neuro Orthopedic Institute, and numerous other things along the years. And it's just been trialed and tested over the years. So, that's my background. There's lots in there.
Fabulous. Moira says, I have a long nursing background, just started as a coach in this area and suffer with pain. Moira, get in touch with Sheren. I'm sure she can help you in so many different ways. And I've got some more questions here, but I'm just going to pop in, before I forget, I'm just going to pop in Sheren's website address. I'll put it in again at the end, just so that you can see that. Paul says, fibromyalgia, often regarded as a phantom pain. What is your experience of it and subsequent treatment? Now, I'm okay to go on for another few minutes. I know we said about an hour. So, but anyone that's registered will get the recording. So if you need to hop off, I completely understand, but you'll get the full recording if Sheren's okay to carry on for a few more minutes.
Yeah, absolutely.
So yeah, fibromyalgia.
The important thing here is we have a little bit of an attachment to labels. And when we work with chronic or persistent pain, labels are like fibromyalgia, which is pain kind of all over, aren't necessarily that helpful. If we just think of persistent pain or chronic pain as your nervous system being overly sensitized to a continuous kind of drip of amplifying messages from the brain. So it might be adrenaline, it might be cortisol over a long period of time, and that sustains this kind of communication between brain and body that amplifies symptoms, and it continues and it continues and it continues. It means that things become overly sensitized. Subsequent treatment, that varies from person to person. So we don't treat the label, we treat the person sitting in front of us. That's really, really important. And the treatment for each person is going to be completely unique to them. But the pain education bit is going to be the same for everyone. You know, there'll be a pain education, and then they'll realize how it works in their life. And then we would tailor it to what specifically is happening and work on that. Does that make sense?
To me, it does. If Paul wants to pop anything else in the chat box, that makes complete sense, especially from what you've already explained.
Yeah.
That, you know, we're all going to be completely different with all those complex different factors.
Absolutely.
Let me just see. Paul says, what, tailoring being a focus on their environment, their lifestyle?
Tailoring a treatment means looking at all the things that are setting off a danger response, setting off those alarms. So yes, environment, what's going on around you. And environment also means what's happening inside the body, but environment around you, all the things you're seeing, you're hearing, you're sensing around you, the things you're thinking, the beliefs you have, certainly lifestyle. If, you know, the connections you have, are you getting your own needs met? You know, are you feeling a deep connection to other people? If you're not, is that lacking? Do you have a connection to the wider community? How secure do you feel? Do you feel like you're achieving things? There are so many aspects to this, but absolutely it's tailoring to that individual and working out step by step all of those things. I'm not proposing for 1 minute that someone sits there with pain and tries to do this by themselves. Certainly they can get started, and certainly they can find out more about how pain works, and that will be a good starting point for them. But digging down deeper and tailoring things, that would be getting in touch with a specialist.
I've got a couple more questions, actually. Helen's asked a question, Catherine's asked a question, so don't go anywhere, I'm getting to it. Helen asks, does anyone have any reference to online or downloadable examples of powerful hypnotic management of pain medications? Just for everybody else, there will be a lot of hypnotherapists on this, as well as people that are experiencing themselves. So she has a ruptured disc in the lower spine and pelvis, which 8 months on has been debilitating. However, with cognitive hypnotherapy and human Givens reading, this is helping. Lovely to hear that.
Great.
Well, I would appreciate any links to self-managed or self-help hypnosis. And she also says it's very useful webinar.
Good. I'm so glad. It's great that cognitive hypnotherapy and human Givens has helped. And I don't know whether, did she say she's a therapist herself?
I'm not sure actually, but maybe if you do you have any helpful links that I could maybe put in an email afterwards when I send out to everybody?
Yeah, my thing is, I think the question is about self-hypnosis.
Yes, it's about self-hypnosis, yeah.
Now, here's the thing again, with self-hypnosis, you know, this is not about taking away the pain in the first instance, okay? Because if the brain is perceiving there to be a threat or danger, whatever that might be, whether that's a belief or a thought process or something that's happened in the past or something that's been picked up from the past, a message from a doctor that's still there kind of firing away, getting to that is more important. Self-hypnosis is absolutely really, really powerful stuff, but using it at the right point in time is crucial here, because if you use it early on and you're reducing symptoms down, you're masking it over and not dealing with why the brain is causing these amplifying chemicals to be released in the first place. So my hesitancy with self-hypnosis is really, really useful, but absolutely use it at the right time. Getting rid of the pain isn't the first thing. Once you've worked on some of those amplifiers and you're kind of on the way, then that's the point for self-hypnosis. In the meantime, you know, relaxation scripts, absolutely see how they go for you. But if cognitive hypnotherapy in human givens has already been accessed through a specialist, a pain specialist in the area, then you may already be in really good hands.
What I'm going to do, just for Helen, I'm going to put in now. Sheren's, we had a chat about this beforehand, and Sheren does offer free chats, so you can talk about all of this. And she has said that if anyone books a free chat and says they're on this webinar, she's going to give you a bit more time, which I thought was really, really nice. So again, I'm going to put that where to book a consultation in the chat box, but basically just go to her website. You'll see a link to that on there if you're interested in that. I really would recommend it, because it may be that one approach is going to be better for you than another. And I know that also, Sheren, you work with people over a period of time as well, don't you? And they've got a group. You've got a group
yes,
program as well.
Yeah, the group program is the Breakthrough Pain program. So the next one is 25th of January. The consultation will chat about, you know, your needs, and then if the program seems like the right approach, then I'll you know, chat to you about the program too. The program has come from years of developing this, and it's a blend of pain education. There are 5 group workshops in there, and this is a small group, and it's all done online. So the same software we're using now, Zoom. Small group of you will start on this 10-week journey with 5 workshops, digging deeper into what the pain biology means for you, what is specifically going on internally with you. And it's a nice supportive framework. And you also get 3 one-to-ones to dig a bit deeper into what's happening personally with you, so we can reduce some of those amplifiers and release some of those lovely happy hormones, if you like, instead. The idea of 10 weeks is that they also have a private Facebook group where they support each other. And this is really important, because I didn't mention this, but I don't know whether you've had this, but where we get information is really, really important. So there are pain support forums and support groups. There are loads of those, whether they're online or in-person support groups. But often the experience is that everyone sits around and has a little bit of a rant about what's going on. And that might be a little bit angry, or might be a little bit frustrated. And what that serves to do is amplify things rather than calm things down. So the idea of the 10-week program is that you're in a group that learns a new way, a way of releasing these happy hormones to keep you and make you more comfortable and feel supported every step of the way. And of course, you get personalized MP3s, etc. But it's a 10-week program. Certainly, if you're booking a consultation and it seems appropriate, I'll talk to you more about it on that call. But certainly, if you're on this call with Cathy and you do book a consultation, please say you were on this call with Cathy, this Q&A session, and I'll give you more time.
That's really generous of you. I've got another question, actually. If we go on from Catherine. Hi, Catherine. Lovely to see you here. And thank you for saying it's been helpful. Catherine says, I work with mums to be preparing for labour and birth. And I know that contraction pain can be very amplified, or not, depending on the emotional state of the mother. Would you say that if a labouring mum is calm and feeling in control, but still feeling in a lot of pain, is that an indicator that there's something else that needs attention? In other words, pain, with a message. Great question, Catherine.
It's a great question. And there's two parts to that, really. One is remembering that that's acute pain and not chronic.
Yeah.
And acute pain serves a really positive purpose. We know, what's going on in that childbirth process. There's a good reason for why pain is there. If the mum is feeling calm and feeling controlled, but there's still a lot of pain, then certainly there may be something else to look at. With labour and with acute pain, this isn't necessarily about being completely 100% comfortable if the pain is serving a useful purpose. Or you might feel it as a different sensation. So you might not feel it like pain, you might feel it as a different kind of sensations instead of pain. But I would certainly investigate whether there's something else going on there, dig a little bit deeper. There may be another layer to explore. Again, it's not just about being calm and being relaxed. There may be other things going on there. Explore thoughts, beliefs, what they've learned from watching, I don't know, Call the Midwife or whatever else,
Those other dreadful programs.
These little messages, they're insidious. They kind of get in the background and they kind of stored away, only to be fired at an opportune moment. So yeah, have a look at some of the other layers, what else might be going on.
Fantastic questions, really. I'm not seeing any more, just having one more. Oh, Catherine says thank you.
You're welcome.
I think I've got all the questions. Thank you guys so much for being so interactive. It's just been amazing. But Sheren, thank you. I mean, it's so enlightening. I love speaking with people like you. I want to thank you so much for giving your time and expertise.
Oh, it's my pleasure.
The links are up there. I'll send another link out to everyone. We'll be sending a link to the recording if the technology is behaving itself. And I'll put in a link to Sheren's website as well if you want to take it further, either as a therapist or someone who wants to explore getting more help for themselves.
Yeah. And there is a contact form on there if you're a therapist and you have a few questions that pop into your head after we finished. Feel free to drop me a line and I'll be happy to answer.
Yeah. Thank you very much again for your time. It's been really good. So getting more notices coming through, really enjoyable.
Oh, thank you.
Oh, it's lovely. Excellent. Thank you guys. That's really, really good.
Thank you,
Sheren, for your time and expertise. And thank you everybody for spending your time and joining with us today at lunchtime.